usually the doctor who certifies the death, or somebody who has been closely related to that, will call the coroner and have a discussion that basically says, we think this person has passed away due to suicide. What do you think? Do you agree? And if there is agreement reached in that call, then it sounds like the circumstances are those of a suicide, then the coroner will record that as such, and then we move on to taking that process through to an inquest. The point of an inquest really is to tell the story of that person. You know, it's not often that we tell stories in that way, but actually, in terms of looking at people who've died by suicide, it's really, really important to understand their stories, understand what led to them to get to that horrible end point, and to really try and dig into this and ensure that we stop this from happening again, to another person, to another family. And then the outcomes of that inquest are numerous. So there are a whole range of different ways that a death at the end of an inquest can be recorded. Death by suicide is one, but there are also other ways that might end up. So it may end up being recorded as an accidental death. It may end up being recorded as a whole host of other outcomes. I've popped a couple of links in the bottom of the slide because I think sometimes this stuff is easier to read about at your own pace. But there's a really good explainer in the bottom of the slides around what that purpose is. I am aware that all sounds very clinical and boring though, so I'm going to hand over to Jess to kind of humanise it a little bit and really dig down into the human side of the process.
Yeah, so I suppose as a person who's bereaved by suicide, I just wanted to acknowledge that whole process around you know, and again, we've got bereaved people on the call who might want to speak for themselves, but the whole process around finding out the shock of the death, the complexity of human emotion that comes with that, coupled with quite an opaque system potentially and a lengthy process for kind of like determining the cause of death, is an incredibly difficult time. And you know, I think it's worth sort of noting, well, it's beyond difficult really. I think it's worth noting that, you know, if we look at suicide bereavement, i.e. people who are bereaved by suicide, friends, families and others, they have greater risk of suicide themselves. So if you are bereaved, your risk of suicide goes up, not just because of the difficulty of that immediate time, but actually ongoing throughout your life. And it's really important to acknowledge that, and for us all to understand at home and at work, if we're encountering somebody who's lost somebody that means something to them to suicide, then they are at greater risk of suicide themselves. Okay, should we go to the next slide, Emma?
Jess, we've just got one question in the chat just to jump in on
the
back of that slide. Marie's asked, please could I ask if suicides of asylum seekers in detention centres are recorded in the same way? Do we know?
So I was just writing a little response to that one, Jo. So the theory is yes. So anybody who passes away in a prison, a secondary mental health facility, or in a detention centre. So anybody who is kind of, for want of a better phrase, under the care of the government at the time that they pass away, or passes away in a hospital but has immediately previously been in one of those settings. That's an automatic referral to a coroner and an inquest. So yes, theoretically, anybody who passes away in a detention centre and we think that the cause might be suicide, that should get referred and should follow the same process.
Thanks, Emma.
All right.
Okay.
Am
I doing this one, Emma, or you? I can't remember.
Oh, you crack on.
So just to say, and now listen, we've got some public health colleagues on this call from each of our places, and so guys, Becky, Jo, I know you're here, Chris, I can see you're here, feel free to chip in on this slide. But the first kind of like look at information we're going to start with is probably our most detailed understanding of our local places, and that is what's called a suicide audit. And briefly, what that means is our public health colleagues, yeah, as I say, many of whom are on the call, in local authorities, actually physically go to our coroners' offices. So we've got 2 in West Yorkshire. There's one that covers Leeds and Wakefield. I think it's called like West Yorkshire East, I think, and one covers Bradford, Calderdale and Kirklees. So we've got 2 coroners' offices, and public health colleagues go there and they pick out the files of all of those people who have died by suicide or may have died by suicide, and really look at what information they can glean from those files. Again, this is incredibly limited because what the coroner, what's talked about at inquest and what the coroner requests is not a complete picture of that individual's life by any means. But what we're doing is we're trying to get the most localised, most detailed information and a closer look at individuals and individual risk factors from those. And just to say that at the moment, West Yorkshire audits are underway. So Leeds and Wakefield are completing one together. Oh yeah, I've just seen you, Rachel, you're on the call as well. So I don't know if you want to come in and say anything at this point. And Bradford, Calderdale and Kirklees are working on completing their audit together at this moment. And we're expecting to get results in next year. And we will ask colleagues to come and present their local findings of their new suicide order at future suicide prevention meetings, and potentially I'm sure they'll be presented in the local suicide prevention meetings as well for each local authority area, if that makes sense. Emma, is there anything I've missed there around suicide audits?
Just to say that it kind of links back to the previous slide where we talked about that rather lengthy process where the death has to be referred to a coroner, then the coroner has to undertake an inquest. Inquests often, in theory, take about 6 months at the moment because of, as I put, their pressures within the system. More generally, they're taking a little bit longer. So that delays the time in which this information is available to people. It delays the time in which the information about the particular method of death gets into those national figures. So when we come on to talking about national figures a bit later, what you'll see is that there is a little bit of a there's a little bit of a caveat around the data around, we think because of COVID, because of the pandemic effects, that actually there's been even more of a delay than we would usually see. But we do always see a delay in recording a death as a suicide because we've got to be really clear about what we're saying about that particular person who's died. You know, it's not an outcome that we're going to bandy around just because we feel like it. We've got to be very, very clear that that is the right outcome for that person and that family. So inquests take a long time, but it does then lead to a lag in the data.
I think there's a further data lag caused by the fact that audits are completed periodically, maybe every 3 or 4 years, not every year. And so again, the audits, you know, that are currently being undertaken by local authority public health colleagues may be looking at deaths that happened in 2017, 18, 19, 20, rather than you know, because they can't be performed, they can't be undertaken every year because it's a massive piece of work.
Yeah.
Okay. Do you want to do the next slide, Emma?
Yeah, I'm getting there.
So I'll just talk about this a little bit. So, you know, everybody on the call can look at their own local audit or read all 5 audits for West Yorkshire or beyond. But their findings are really complex. But I just wanted to pull out, I thought it would be a bit useless if I explained what an audit was and then didn't pull out some of the key themes. So usually what they show is in people's life, there's a combination of long-standing risk factors coupled with recent life events that happen prior to an individual's death. So being a man, being in middle age, of either gender, sometimes there are things like relationship breakdown, alcohol use, financial difficulties is a big one, physical and mental health problems, isolation and or bereavement. And I've just realised I should have written bereavement by suicide especially on this slide. So all of those things are common risk factors that are found through each of our audits, just to kind of really draw out at this point, if that makes sense. And so those are the kinds of things, I suppose, that are going on in people's lives, or a combination of those things that kind of all stack up and cause an individual to make that decision to end their own life. Physical health problems are really common. So people working in mental health services should never underestimate, I suppose, the interface between an individual's physical health and their mental health, and how that can lead to hopelessness and, I suppose, financial difficulties. I can't not say this at this time of year, with our economy in the state that it's in, and the impact of that of poverty on people, of job losses. That's a thing that we're all worried about at the moment, in terms of financial exclusion, debt, gambling, job loss, poverty are all tend to be risk factors as well. Does anyone, I just want to check if any of my public health colleagues want to jump in at this point and add anything to what Emma and I have said around audits, because I think that's our last audit slide.
I think so, yeah. We're very aware that neither of us have done an audit before, but somebody like Becky, who's got a hand up, probably has.
That was such coincidental timing there. Yeah, I was just typing it in the chat, but I'll just jump in. It was just to say that just touching on that point that you said about the audits being retrospective and looking at sort of they often feel quite old at the time that we're doing them, but nevertheless they are really they provide that richness behind the numbers. So if you just look at the numbers like we get on ONS, you don't really get the kind of insight behind the numbers, and that's what the audits really give us. So sometimes at a local level we might hear things about suicide that we might know from our audits aren't entirely accurate. So they really allow us to provide that local challenge to say, actually, this is what we know. So they really do provide the kind of backbone to our local work, really, despite them taking, obviously a long time to kind of organise and get going with. But like Jess said, we are kind of on with that now for the Kirklees, Calderdale and Bradford one. So, yeah.
Brilliant, thanks Becky. So just to say to everyone who doesn't know Becky is the public health manager for Kirklees, it's all right, and also the senior responsible officer for suicide prevention across West Yorkshire alongside 3 other colleagues. So thanks Becky for that. Chris, I can see you put your hand up as well. Do you want to come in?
Yeah, it was.
Say who you are first, Chris.
Oh, sorry. So I'm Chris Watt, I'm part of the public health team in Wakefield Council, and Leeds and Wakefield are undertaking their suicide audit at the moment. And it was just to add that is maybe some people might be wondering why we don't do it every year. It is very time consuming. We've got our data analysts from Leeds and Wakefield in at the moment in the coroner's office. It's obviously looking at very sensitive information, so it's not something that you do and box it off within a couple of weeks. You know, it's a couple of days a week to obviously allow the people that are doing the research and looking at the data, time in between. And yeah, it does give a really fuller picture. But I think we've underestimated, although from when we did our last audit over several years ago, they were just looking at the coroner's records in a paper format, that now they're digitally on the computer system. It's still a matter of reading through the coroner's inquest and picking the detail out and then putting it on a spreadsheet. So it's very time consuming. I think we started in October. Like I say, it's not every day of the week. But we're maybe looking at, between ourselves, Wakefield and Leeds, we're looking at maybe 450 cases. So it's potentially going to take us into throughout January as well. I think we thought we'd be done by Christmas, and that's just the data collection point. Then there's analysis thereafter. So yeah, it's a lengthy process, but it's the information we get enables us to add the detail into our strategies and action plans in terms of initiatives to prevent loss of life through suicide.
Brilliant, thanks Chris. Rachel, do you want to introduce yourself and then make your point?
Yeah, sure. Hi, I'm Rachel Brighton, Public Health in Leeds City Council. Chris just basically said what I was going to say right at the end there, is that we'll use all of that information to help us with our local action plans and strategies, but it also helps us target our interventions, target our funding, and help us really have that sort of coordinated impact to doing local work across our city. Thank you.
Thanks, Rachel. And then Jo, do you want to say who you are?
Hi, I'm Jo James, so Public Health Specialist for Bradford. And I was just going to echo what the others have already said about that, the audit, but in terms of the 3-year thing, it is a huge piece of work, as we're discovering now, undertaking that in Bradford, Kirklees and Calderdale. But there is a utility to that length of time as well, just in terms of what Emma was saying at the start about small figures. If we take a snapshot over a longer period of time, that helps us be a little bit more certain about some of the things that we're seeing as well. So there is some utility in it taking longer. It's not just a case of resource that decision is based on. So I was just going to add that as well.
Thanks, Jo. That's, yeah, too true. So yeah, audits you can expect at some point in 2023, and they will give us the richest and clearest information around individuals' lives. I hope that makes sense. Okay, should we move on?
Yeah.
So go on, Emma.
Yeah, a little bit of an explainer on surveillance next. So for public health colleagues on the call, apologies, you'll probably be very familiar with this sort of thing. So the next bit of information that we were going to look at was the West Yorkshire real-time suicide surveillance system, which is always a bit of a tongue twister for me. And the point of surveillance really, and this is the key bit to take home, is information for action. So with my public health hat on, there is absolutely no point in collecting information or data on something if you're not going to do something with that. You know, we can all collect all sorts of information about whatever we fancy, but if we're not going to do anything about it, then really you've got no basis in doing that at all. And so the surveillance system really is the kind of the truest representation of information for action. It kind of came from infectious diseases research and things like that. So we've got lots of surveillance systems out there. Most of them are around things like flu, meningitis, TB. We do surveillance when we have outbreaks of food poisoning, all things like that. But in recent years, what we've seen is a taking of the theory and applying it to what we call sort of non-communicable diseases, or sort of modes and methods of death or injury, trying to see if we can use those principles in a different way to help us collect information that we can then do something really useful with. There are 5 types of surveillance. To my mind, the enhanced surveillance best describes what suicide surveillance systems should be doing. So enhanced surveillance is really about getting into the detail of every person or every incident that you put into that surveillance system, and understanding what's gone on, what are the risk factors, what are the links here, what are the themes, what's the story. So that's really what we're trying to say. That's really what we're trying to sort of cover off with our surveillance systems. I just thought I'd do a quick run through of what a good surveillance system looks like, and then Jess is going to kind of tell you a little bit more about the West Yorkshire system and do a bit of a compare and contrast and sort of say where we're really having success across West Yorkshire and where we've still got a little bit of a way to go to get to these kind of 7 key aims. So first off, you need to describe the event that you're looking at, and really we need to know if it's preventable. And I think, you know, across West Yorkshire, we really kind of aspire to, we ascribe to, we believe in the zero suicide approach. You know, suicide should be looked at as a preventable death. There should be no need for somebody to die in such tragic circumstances. So, you know, I think actually a surveillance system looking at suicide deaths fits that criteria quite nicely. We think it is preventable. You need to have a little look at the system in the round, and how are you reporting the data, how are you storing the data, how are you evaluating the data. And certainly I think when Jess comes on to talking about our system, there are a few little bits in there that I think we could probably be tweaking and changing a little bit to make it more useful for our whole system. Reporting is always the one that surveillance systems really struggle with. When you've got a collection of so much data, there's always a question around, do I tell everybody everything? Do I create very bespoke reports? Do I tell some people some things? And trying to get that balance between how much information is too much information is a real struggle for surveillance systems the world over. We want to critically appraise the available sources of evidence, and that's essentially what we're doing this morning. what we're doing is we're going through all the different sources of data that could be fed into this suicide surveillance system and saying, actually, this is really good because it's quick or because we can get hold of it really easily, but it's not so great because it's a bit inaccurate sometimes, or this source of data is great, it's really rich, it tells us everything we need to know about that person, but we have to wait 18 months to get our hands on it. And actually, what effect does that time delay have on our ability to use that information to create that action that I talked about in the beginning? So really important to kind of be aware of the data that you're putting into your surveillance system and what the good things and the bad things about it are. A surveillance system is only kind of helpful if it's useful. So who is going to do what with what that surveillance system chucks out at the other end? Again, it relates back to the information for action point. So if you're going to produce beautiful graphs and reports from your surveillance system, and then somebody somewhere in a closed office reads them and goes, oh, that's nice, and puts them on top of their done pile, pointless. Why are you putting your energy into a surveillance system? So what you want is a really clear, coherent vision for when I produce this graph, this report, that person in that office over there is going to do this. That person in that organisation over there is going to do this. And you need a really clear system for holding people to account for using the information that you are providing them with. The systems like this cost money, they require resource. I can see Stuart on the call. Stuart is a really important resource for West Yorkshire. He is doing an awful lot of work to make some of this suicide surveillance stuff work for us. High quality in a surveillance system is what you're really aiming for, and we've got all of these quality criteria here. So is it simple? Can anybody use it? Can anybody understand it? Is it flexible? If you see a real change in what suicide looks like, what the risk factors look like, can that system flex and change to incorporate that data really quickly? Is it timely? That's one of the big bits that we're really grappling with suicide. So there's a whole raft of quality factors that it's really important to continually be reflecting on as a team running a suicide surveillance system to say, are we hitting all of these key points? And then that leads us into point 7, which is continual improvement. And this kind of runs across the whole of what all of you on the call do in your day jobs. You know, there's no point turning up to work and saying, yeah, I've done an all right job. You want to be improving, you want to be achieving more, you want to be changing things, and that's just as important with the surveillance systems. So now I've kind of run through the 7 key bits. I can see Jess's face absorbing them. So yeah, Jess, how is it working for us in West Yorkshire?
So just to be really clear, our real-time surveillance system for suicides is a police-led system. So what that means is that so Stuart, who Emma mentioned earlier, do you want to say hello to everyone, Stuart? I know you probably don't really, but I'm going to make you.
Hi everyone, yeah, I'm Stu, Suicide Prevention Coordinator for West Yorkshire Police.
Thanks, Stuart. So Stuart is funded by the ICB, sits and is employed within West Yorkshire Police and does a brilliant job of instigating our real-time surveillance system. And what that means is Stuart is looking at suspected suicide cases or cases that police officers may suspect are going to be determined by coroners as suicides over the next year or so. In real time, so as and when they happened, and then feeds that information to our local public health suicide prevention leads on a weekly basis. So it's a real brilliant collaboration between West Yorkshire Health and Care Partnership, local authority public health teams, including their data analysts, West Yorkshire Police, and also the bereavement service, which is provided by Leeds Mind right across West Yorkshire, which I should have written on this slide. And we are working towards bringing in data from other partners in real time as well, and those partners might be Yorkshire Ambulance Service, British Transport Police, Network Rail, etc., in order to give us a full picture of what's happening day to day across West Yorkshire. I hope that makes sense. I'm just going to say, Emma, we're at 10:10 now, so we're going to have to speed up or we're going to run out of time on this one. So so the challenges, you know, I think what we've done, so just to go back to the benefits, the brilliant thing that we've managed to do in instigating this partnership is A, give public health colleagues real-time information about potential suicides in their area. B, Stuart's there as a resource for kind of constant communication and interaction, which I know is happening around that, to check out for patterns. And C, one of the most important things is create a consent process for referral of people who are bereaved, witnesses or suicides to the suicide bereavement service. So that risk factor that I talked to you about earlier on, being bereaved by suicide, is improved by this surveillance system, because not only is it a data sharing system, but it's a referral system as well, so that anybody who's in West Yorkshire who has lost somebody to suicide is asked by Stuart for their consent to pass their details onto the bereavement service, and then the bereavement service attempt to proactively contact them, so that in order to offer them support, triage, give them information and help them through that process that I described earlier on. And we've had a brilliant take up of that. So challenges, getting clarity around data sharing agreements is a little bit difficult, and knowing what's appropriate to share where and how we can use that data is difficult. There's kind of like clunkiness within the system. It isn't as smooth as we'd all like, and there's a kind of like number of partners to take into consideration. And also I've just put here about the shock of a recent bereavement, because I suppose the difficult thing is in the immediate aftermath of a suicide, it may not be the best. It is for many people the best time to kind of like engage and offer that support, but for others it may take longer. And so Stuart always passes on details of the bereavement service, so that if someone doesn't consent at this time, they may well look up that access that service into the future. There's no perfect time really to to offer support, but what we're trying to do is have a system whereby we keep going back to people to make sure that they are given the help that they deserve, and that's you know, out there for them. And just to say on the bereavement service, it is peer led. I think Lisa's on the call from the bereavement service, and I know Roz is too. It's delivered by people who are bereaved themselves, and so it really is a kind of unique and high quality service, and we get excellent feedback from service users about the help and support that's offered by that service. So again, if you are supporting somebody or know somebody in your personal life who's bereaved by suicide, they are always welcome to self-refer, or you could refer them to with their consent to the bereavement service. Okay, next slide, Emma.
Okay. Just moving on to the national data then. So we've got two kind of sources of national data. We've got Office of National Statistics data, put my teeth back in, and we've got the fingertips data, which is produced by the Office for Health Improvement and Disparities, which is part of the Department of Health and Social Care, which is an awful lot of long words to basically say some public health people who work in a national role. Fingertips uses the Office for National Statistics data, so they are both based on the same data sources, which is national reports of people's deaths following inquest. So these will be the kind of the time lag data. So these are the ones that are confirmed by our coroner's inquests to be suicide. So it's the same data in both of those platforms, but what you will find is that they display them slightly differently. ONA's data is released in a once yearly report. Fingertips data is updated on a bit more of a sort of rolling basis, as and when it can be. And also, one of the benefits I find with Fingertips is that it's much easier to compare areas. So I was going to give you a bit of an explainer, but I think we'll skip over that for now. But both of those links in this slide are live. The ONS data will take you to the latest release page. The Fingertips data takes you straight to the suicide kind of markers that I've searched for. Have a little play if you're interested. If you're struggling with finding your way through Fingertips, because it is, in Jess's words, a little bit clunky, please do contact me, or I'm going to put the public health guys on the spot. I'm assuming if anybody contacts their local public health department, somebody will be able to point them in the direction of somebody that can give them a bit of a Fingertips explainer, because it's always a bit always a bit all over the place, but it's got some really good ways of breaking the data down, allowing you to compare yourself to different areas. And also, if you really have a little look into it, it's got some really good data on risk factors for suicide as well, which Jess has already alluded to earlier, so that you can understand what risk factors are most prevalent in your local area as well, and try and target some of your work towards that. Jess, I will hand back to you and you can decide which of these to focus on.
Yeah, so what I'm going to do now is I'm just going to go through the latest ONS data for our region really briefly. And again, you'll get the slides. And this slide, I'm not going to talk to it actually, but it's just to really set, this is taken directly from OHID's Office of Health Improvement and Disparity slides, and it's their explanation really about that suicides are based on the data, the date of the death registration rather than the date of death occurrence, which I think we've explained, and that there are registration delays. So just to say, last year in 2021 there were 5,219 suicide registered in England, and that's so the English rate of suicide death is 10.5 deaths per 100,000 people. And that was not a statistically different in comparison to 2020 rates, where it was a death of 10 deaths per a rate of 10 deaths per 100,000 people. And it was also consistent with the pre-coronavirus pandemic rates in 2019 and 18. So roughly for the whole of England, we've seen a kind of like a broadly level death rate since 2019. There was a slight fall in the death rate in 2020, and that was probably driven by a decrease in male suicides at the start of the COVID pandemic, but also those delays in registrations because coroners' offices, inquests weren't being heard at the same in the same way as they were before the pandemic. So there was some delays. And yeah, just go to the next slide. I suppose the important thing around gender is that 3/4 of deaths were men. And so this, you can see here, they produce age standardised suicide rates for England and Wales, and you can see that the Yorkshire and Humber one there is kind of in the middle at 12.3. So the England average is 10.5, Yorkshire and Humber average is 12.3, and you can kind of see where other kind of broader regions compare. Okay, moving on. So this is a little bit complicated, and I just wonder, Emma, if you could hover your cursor so that to show people what I'm talking about. But basically this relates to age, and if you look at the columns down, we've got 1981 would be the first column, and there's one every year up until 2021. Okay, so a column per year, so we're reading across in years. And then what they've done is they've grouped the age of death, the age of the individual at death, into 5-year intervals. And so what the slide, I suppose, is showing you is that in 2021, the darker the colour, the more frequent the deaths. And so it does tend to get darker around that sort of middle age. And you can see that there's been a change over time. So like in the early 80s, for example, suicide deaths were much more common among the older age range than they are now, because obviously those squares are lighter now. So it's just some interesting patterns in age over time and how they change. So the lighter the colour, the lower the suicide rate. OK, next slide, Emma. Yeah, should have said another trigger warning before this slide. I really apologise, but this is just to show that they do show how people take their own life, the method, and you can see that hanging, strangulation and suffocation is the most common cause among men and among women. OK, next slide, Emma. So this is a bit more of a local breakdown of, again, the rates. So that's our most reliable source of information. From the ONS data we can get counts, that is a number of people who took their own life, but this is our local data on those rates, and the black lines going up and down from the bars sort of show the confidence interval for each of our places. So you can see Wakefield, Calderdale, Leeds, Kirklees and Bradford rates there. So, you know, sadly, all of our places have rates above the England average, and some of them above the Yorkshire and Humber average for last year. That's not a 1 year's data, sorry, that's a 3-year rolling average from 2019 to 2021. In September this year, we'll get a 3-year rolling average from 2020 to 2022, if that makes sense. And so that's what the ONS is producing each year. The orange line there is the Yorkshire and Humber average, and the blue line is the England death rate, if that makes sense. Is that okay, Emma? And so again, I'll send these out, but this is just to show the change in time. Sometimes we hear people saying, you know, suicide death rates are going up exponentially, and there's a big rise, and it's worth looking at the average data over years just to kind of fact check some of that really and see what's really happening. So this is the Bradford slide. So you can see there that Bradford's got a suicide rate that's lower than the England average and has decreased in recent years with fluctuations. So probably in recent years, the highest was in around 2010 to 2014. Joe may want to talk to this slide more than me, but you can see there's fluctuations and how they compare. The grey line here is the Yorkshire and Humber average. So yeah, so some protective factors potentially happening in Bradford there, but again, the complexity of this data, it's really difficult to really know what's going on. Okay, next one is Calderdale. So again, we can see recent rises in Calderdale. Actually, the numbers of people taking their own lives in Calderdale is incredibly low. So then this can give rise to greater skews in the rates data, if you understand what I mean, as it changes. But lots of work going on by public health colleagues in and around Calderdale at the moment to really bring that rate down. And again, it's really tricky to know about the impact of delayed inquests because of the pandemic and how that will play out in the next year's data, if that makes sense. Going on for...
Yes, I was just going to add on that one because I think it's a really nice demonstration. So
yeah.
3-year rolling averages, the reason we work those out, so we take the data for 3 years, we add it up, we divide it by 3, essentially, we create one figure. The reason we do that is to try and sort of what we call smooth out the line, and the higher the counts that we're working with, the smoother we can make that line, and therefore the more easy it is to interpret. And so what you can really see on this one is that the counts for Calderdale are so small that your line is really jerky, it's up and down, you know, the differences are really quite big. As you move into bigger areas, so Yorkshire and Humber, you've got a slightly smoother line, but it's still a bit jerky, it's jumping around a little bit. And then the England line, which is looking at all of the deaths by suicide together, is a much smoother line. And so it really kind of shows you the importance of, actually, if you've got more data to look at in one go, you can get a bit of a smoother, clearer picture, and you can be less distracted by big jumps and big drops. And then when you've got smaller areas and smaller numbers of data, those big jumps and those big drops sometimes look really scary, but actually may not be so. And that's when you've really got to do the digging into the data through the suicide audits, through those kind of local stories, to really understand what's causing those big jumps. But I think this is just a really nice demonstration of that kind of difficulty with small numbers and things like that.
So we'll just whistle through now. So Kirklees again looks flatter, and again rates going on and around and circulating around the England average. Kirklees dropped in the recent data release. This is Leeds. So Leeds does have the highest counts, as you would imagine, as it's the biggest city for West Yorkshire. And again, you can see a slight increase there in recent years. Oh, thanks for answering the question in the chat there, Becky, around the place of death is not reflecting this data. This is the address of the individual. So this is about where they lived. Okay, and then lastly, 5 minutes left. Here's the information for Wakefield, and exactly the same caveats that Emma explained with the Calderdale slide also apply here. Wakefield counts are low, but the rates do show that they're rising. Okay, does that make sense? I'm going to also point you towards academic research, which is kind of like our fourth sort of set of data that we use, and there's loads of examples of this, but in particular the National Confidential Inquiry into Suicide and Self-Harm annual report looks in really great detail about deaths at people who are in contact with secondary mental health services, and they have been doing that since I think it's 2009. So every year they add new data to that data set and produce a brilliant summary report, and also a YouTube summary of findings. Again, I can't play it now, but the link is there and it's brilliant. And another example would be the report into deaths of suicide by suicide of middle-aged men that they did. Really thorough look at the national picture there as well. So the NCISH website is really good for finding out information about particular cohorts. They've also done a really good and detailed study into every child death too, not so long ago, and that gives us a lot of information about what's happening in children's lives prior to them taking their own life. The counts are really small there, but the deaths are obviously horrendous and highly impactful.